Hello everyone, my name is Camila. I'm from Federal University of Espírito Santo, and today I will present my work, Systemic Inflammation and Tumor Microenvironment in Oral and Oropharyngeal Squamous Cell Carcinoma. So, as many of you know, inflammatory cells, cytokines, and associated growth factors are involved in many carcinogenesis processes by supporting tumor cell growth, survival, proliferation, migration, and immune escape. And as inflammation is strictly related to cancer, the impact on prognosis has been explored, and it has been shown that the high levels of systemic inflammatory markers, like the neutrophil lymphocyte ratio, are associated with reduced survival in cancer patients. The poor prognosis associated with systemic inflammation could be explained by the role of the immune cells in the tumor microenvironment, the TME. While immune cells, like the lymphocytes, can control tumor growth by recognizing and killing tumor cells, other cells can create an immunosuppressive TME by suppressing these activated immune cells, which may lead to a worse prognosis. So, our study aimed to investigate the prognostic impact of systemic inflammation and tumor microenvironment in oral and oropharyngeal cancer. To address this, we retrospectively selected 199 patients from 2 centers, one in Brazil and one in United Kingdom, between 2005 and 2017. To evaluate the prognostic role of systemic inflammation, we calculated the neutrophil lymphocyte ratio from absolute counts of neutrophils and lymphocytes available in pre-treatment CBC in the medical records. And to find the optimal cutoff for NLR, we plotted our ROC curve. To evaluate the prognostic role of the TME, we recovered tissue samples and we evaluated the infiltration of lymphocytes, the TILs, and tumor-associated neutrophils and PD-L1 status. The TILs were scored in HE10 sections at low magnification, and then they were classified into low, moderate, or high. We follow the score system proposed by Ward and colleagues, which define lows as the presence of TIL in less than 20% of tumor and stroma, moderate between 20% and 80%, and high in more than 80% of tumor and stroma. The PD-L1 status was determined by immunohistochemistry using an anti-PD-L1 antibody from Abicam, and we counted the tumor cells and immune cells expressing PD-L1 to determine the combined positive score, the CPS. The tumor-associated neutrophils were also analyzed by immunohistochemistry using an anti-elastase antibody from Abicam, and to determine the density of neutrophils, we selected hotspot areas at low magnification, and then we counted these areas at 400 magnification. The neutrophils were counted in intratumoral and peritumoral area, and the average density was used as a cutoff point. So our results showed that the best cutoff for NLR was 1.85, which is this value based on the area under the curve, and the sensitivity and specificity values, which were 83% and 50% respectively. Based on this, we divided the patients into 2 groups, low and high NLR, and we found a correlation between high NLR and smoke and alcohol history, and larger tumors and advanced disease. In survival analysis, we found that high NLR was associated with shorter survival, overall survival, in patients without lymph node metastasis. The low levels of TIL was also a poor prognostic factor in our study. Patients with low TILs present worse overall survival and disease-free survival compared to the moderate and high groups, but the density of the tumor-associated neutrophils and the PD-L1 status were not associated with survival data and any clinical pathologic features. However, we combined these 3 markers into a score system to classify the TME into 2 groups, immunosuppressive and non-immunosuppressive. So tumor samples with 3 or 2 of these markers were classified as immunosuppressive, and tumor with 1 or none of these markers were classified as non-immunosuppressive. So we hypothesized that a TME with low infiltration of TILs and high peritumoral neutrophils and PD-L1 positivity is immunosuppressive and predicts a worse prognosis. And when we look at our results in survival analysis, we observed that patients with immunosuppressive TME present a worse overall survival compared to the group with non-immunosuppressive TME. So studies have shown that neutrophils and lymphocytes have different and maybe opposite roles in carcinogenesis. Neutrophils may produce cytokines and enzymes which may support immunosuppression, tumor growth, tumor cell invasion, metastasis, and angiogenesis. On the other hand, the lymphocytes are the main cells of the anti-tumor immunity, and they can suppress tumor growth by inducing tumor cells apoptosis and suppressing the proliferation and migration of these cells. So the NLR reflects the balancing between anti-tumor and pro-tumor responses in cancer, and the high NLR may suggest an imbalance between these two responses. Other studies reported high NLR as a full prognostic factor in many types of cancer, including oral and oropharyngeal cancer. And our results suggest that the mechanism of tumor aggressiveness in patients without lymph node metastasis may come from inflammation. So for these patients, the NLR may be a good prognostic biomarker. About the prognostic role of TME, our results confirm what other studies have reported, that the low levels of TIL predict as a worse prognosis. The TILs have been widely studied, and it is believed that the abundance of TIL indicates that the anti-tumor immune response is strong, which may contribute to favorable survival in cancer. Regarding PD-L1, although no correlation was found between clinical pathologic features and survival data in our study, the expression of PD-L1 in TME has been considered the main immunosuppressive mechanism in head and neck cancer, but its prognostic role remains uncertain. Two meta-analyses involving about 3,000 patients with head and neck cancer showed that there is a significant variation in results of PD-L1 expression, which limited its use as a prognostic biomarker and in clinical practice. Regarding tumor-associated neutrophil, they have been described with two phenotypes, pro-tumoral and anti-tumor and pro-tumor phenotypes. The tumor cells modulate this polarization through the production of some cytokines, and our results suggest that the peritumoral neutrophils have a pro-tumoral phenotype in oral cancer once they were correlated with shorter survival in the score system that we propose. In fact, studies with hepatocellular carcinoma, laryngeal, and esophageal squamous cell carcinoma showed that peritumoral neutrophils present a pro-tumoral phenotype, producing molecules to support tumor growth, angiogenesis, and immunosuppression. And in these studies, the high levels of neutrophils in peritumoral area was a predictor of unfavorable prognosis. So in oral and oropharyngeal cancer, the phenotype of peritumoral neutrophils remain uncertain. So further studies are necessary to elucidate their phenotype in order to clarify their function in TME and their prognostic role. So in conclusion, although some biomarkers alone do not relate to prognosis, when combined, they may reflect the crosstalk in the tumor microenvironment. Therefore, our findings will highlight the importance of a score system involving TME-related biomarkers to analyze the survival of patients. And more studies should be performed to validate the usefulness of these markers in larger series. So I would like to thank our partners, the hospitals involved in this research, and our funders. Thank you so much.
Dear experienced and scholars, my name is Jin Tao Yu, and I work in the first affiliation at Hospital of China Medical University. My tutor is Professor Baosen Zhou. The subject of my report is development and validation of an individualized immune progress signature in head and neck squamous cell carcinoma. The major objective of this study is to explore a prognostic biomarker for head and neck cancer to improve the prognosis of patients. Head and neck squamous cell carcinoma is a common malignant tumor originating from mucosal epithelium. Despite the repeated development of treatment methods, the overall survival rate of head and neck cancer has not been significantly improved in the past 5 years. The immune microenvironment and the effective of immunotherapy of head and neck squamous cell carcinoma has been attracting widespread attention in the occurrence, development, and treatment of the disease. Therefore, screening the immune genes with poor prognosis is helpful to understand the disease characteristics and improve prognosis. Material and method. RNA sequence database was downloaded by the Cancer Genomic Atlas, and we selected 591 immune-related different expression genes came from import and inner database. There were including 142 down genes and 449 up genes by differential expression genes. And then we further screened 105 characteristic genes by WGCNA. The results were mainly concentrated on immune regulatory pathway and inflammatory pathway by enrichment analysis. And next, we try to confirm the prognosis signature among these 105 candidate genes. We perform univariate and multivariate Cox regression analysis to screen their prognostic roles in head and neck squamous cell carcinoma patient. This 6 was univariate result. 3 prognostic immune genes was defined as prognostic genes was multivariate, including DEFBI, PTX3, and SEMA3G. According to the risk of patient, we divide patients into low and high risk subgroups by the median value of risk scores in each dataset. The Kaplan-Meier survive and time development ROC curves were applied to evaluate the predictive actuary risk model. The value of AUC equals 0.636. Calibration curves were used to assess the consistency between predict and actual survival outcome in 3 year and 5 year. The result indicate that they are fitting. We also try to find some relationship between clinical information and the results show us the high-risk group may affect prognosis by clinical stage rather than physiological grade. Furthermore, we want to explore the correlation with tumor immune microenvironment. We calculated immune cells and immune infiltrations between these two groups and construct Kaplan-Meier curves based on immune infiltration results. This immune-related data was came from several sources and single-sample GSEA. We found there are many immune cells different expression similarity between high and low group, such as T cell, mast cell, and macrophages. In the meanwhile, we found something interesting in the result. For example, our result showed M2 macrophages play an important role in high-risk group, which were consistent with the M2 macrophages tumor protein action. P-value less than 0.001. The result of SSGSEA show us the result of all macrophages were not significant. This maybe means the effects on tumor prognosis among different subtypes of macrophages may be antagonistic. Next, we try to find whether modern genes are associated with immune checkpoint inhibitors. Generally speaking, active immune cells will benefit to our self-defense, pathogens infection, and cancer cell development. But excess immune active can also cause allergic reaction. Thus, immune checkpoint genes has an important role in physiological function and pathological process, including immune homeostasis, defenses, and survivalize, and so on. We established a correlation analysis between immune prognostic signature genes and immune checkpoint inhibitors, such as PD-1, CD274, PDR1, AVCR2, CTLA4, and IDO1. Many genes were markedly positive correlated to ICP therapy. Finally, combined with previous research, we believe that PTX3 was the key genes. We collected 30 head and neck squamous cell carcinoma clinical samples and validated the expression levels of PTX3 by immunohistochemical method. A and B is negative expression of PTX3 in normal squamous epithelium. Left was 200 times version, right was 400 times version. A C and D was positive expression of PTX3 protein in head and neck cancer specimen. A limitation: more functional experiments in laboratory and more clinical trials need to verify this risk model, and the interaction analysis with the characteristic risk factor of head and neck squamous cell carcinoma needs further verified in future, such as smoking, HPV infection, and TP53 highly expression. The information of POC RNA sequence has some limitation. We need unique single-cell sequence database to further research tumor development and prognosis. Inclusion: PTX3 is a key immune gene which may contribute to poor prognosis of head and neck cancer by affect tumor microenvironment. Our study contrasts immune-related prognosis genes model and evaluate the correlation of immune checkpoint inhibitors genes in head and neck cancer. In this model, we thought PTX3 is a key immune gene, and this result brought a known more biomarkers and promising avenues for immune inhibitors in head and neck cancer. Thanks.
I have one question to each speaker. So I will start with Camila, sorry, with Camila. When did you see those tertiary lymphoid-like structures, like in the infiltrates? You didn't see those?
No, I don't.
Okay, great. So you did cuts of what? You cut them in small 4 micrometers. Your FFPs.
For HE sections, we cut it in 5.
5 micrometers.
Yes.
Okay, and so they were mostly, I forgot, they were mostly tongue?
Yes, most of them were tongue. We have 48 from oropharyngeal, and the rest of them were from oral cavity, and most of them were tongue.
Right. And can you also tell me, please, they were late, or what's the proportion of late stage?
About 60% were late. 60
6%.
to 7% were late.
Okay, so maybe that, because I think we are seeing that in the late stage, those tertiary lymphoid-like structures, they are full of B cells.
Yes.
And so you didn't see any of these?
No,
Great.
because for TIL, we do not perform immunohistochemistry
Okay.
to identify the TLS.
Great. Thank you.
Thank you.
Congratulations for your work.
Thank you.
So,
Okay, I'm going to try to summarize that. So the idea is to have a better description of the tumor microenvironment and to try to analyze all the characteristics of the tumor microenvironment and how to associate them with the different risk factors, including smoking, alcohol consumption, matter consumption for them, HPV, inflammation, and to see if there is any association or relation between the presence of those risk factors with the different histological characteristics of the tumor microenvironment. And in that way, if we have a better picture of the tumor microenvironment, then we can decide if there is a possibility to improve the treatment using immunotherapy for those specific patients.
Yes, now the tumor microenvironment has increasing interest because of the immunotherapy. So by analyzing the tumor microenvironment, we can find the potential patients to receive the immunotherapy. And also, this may help to stratificate the patients. We did not did this work in the study, but it may be in further analysis we can analyze the potential of this core system and the tumor microenvironment related biomarkers to stratify the patients. And some studies have shown that the immune score into the TMA stage improve the TMA stage in order to classify the patients and to identify the patients according to the prognosis. So maybe this is further analysis that we can perform to evaluate this clinical application.